Hi. Secondary angle closure nanophthalmos is probably the greatest clinical challenge that a glaucoma specialist will ever face in their career. Cataract surgery alone, even when feasible, can result in an uncontrolled pressure. Decompression of the anterior segment relative to the posterior segment is likely to result in aqueous misdirection. Decompression of the posterior segment is likely to result in retinal or uveal effusions. The case illustrated in this video represents a not atypical presentation. I hope you find it interesting.
This is a phakic eye with no previous surgery, an almost non-existent anterior chamber, a best corrected visual acuity of 660 with an intraocular pressure of 34 mm of mercury on 3 drugs, as well as Tobrex to counteract the irritation from the Ganfort. There's been no previous surgery apart from a laser iridotomy. There are 360 degrees of posterior sneaky eye and the anterior lens capsule is covered with pigment. The axial length is 16.2 mm. The ocular coats are 2.8 mm thick. At presentation, the history was suggestive of microspherophakia, but on B-scan, the lens configuration and size were normal. Although the normal lens occupies a third of the axial length. And the optic disc also appears cupped on B-scan. The fellow eye is similar, with a best corrected visual acuity of 630 and an intraocular pressure of 24 mm mercury on medication. Also with a flat anterior chamber, a patent laser iridotomy, 360 degrees of posterior sneaky eye, and pigment splattered all over the anterior lens capsule. However, the right eye requires more urgent attention. The management of nanophthalmos is not easy. Watch this space for the management and progress. Thank you for watching.